Good afternoon, everyone. Welcome to yet another edition of the continuing education webinar series conducted by Vijaya Diagnostic Center. I thank you for joining us today. I am Dr. Kumar Chaudary and I am HOD and Senior Consultant in Department of Biochemistry at Vijaya Diagnostic Center, Hyderabad. Today, we are presenting the markers of metabolic syndrome to be presented by Dr. Abdul Rahman. Metabolic syndrome is a cluster of conditions that occur together, increasing the risk of heart disease, stroke, and type 2 diabetes. Hence, there is a need to identify at appropriate time through right choice of markers, followed by appropriate actions towards reducing risks, which includes lifestyle changes and weight loss. Our presenter today, Dr. Abdul Rahman, is consultant biochemist at Vijaya Diagnostic Center. He completed his MD in biochemistry from Jorat Medical College, Assam in 2021 and has 2 years of experience in the subject after post-graduation. If you have any questions during this presentation, please type them into the question box in your control panel. I'll bring them up after the presentation and we'll also have time for questions at the end. Now, without further ado, we'll turn the time over to Dr. Abdul Rahman. Dr. Abdul Rahman, please.
So good afternoon, all of you. So today we're going to discuss about metabolic syndrome and markers. So my name is myself, Dr. Abdul Rahman. I am a consultant biochemist at VDC HMNR branch. So it is a very nice opportunity for me and for all of us to have a session like this, and especially thank all of my seniors for hosting and helping and guiding me for this presentation. So markers of metabolic syndrome. So first of all, this metabolic syndrome was first discussed in the year of 1947 by Professor Raven and other co-associates. So then they observed that patients having higher obesity on the upper part of the body, and especially those patients which are having obesity in the upper part of the body, they are developing diabetes and cardiovascular risk factors. So in the year of 1950s, the name of metabolic syndrome was kept. Then another ongoing research was carrying out regarding this subject, and in the year of 1977, it has to be found that more cardiological problems with diabetes and other factors are also involved. In the year of 1988, the term metabolic syndrome was introduced previously, now incorporated with insulin resistance. So it's actually culmination or combination of metabolic abnormalities, but when occurring together, increase the risk of developing cardiovascular disease and diabetes. So the term metabolic means it's a unique disorder affected due to lot other factors like weight gain, our diet, our genetics, our abnormalities, dyslipidemia, and various other factors. So I hope I'll be seeing the slide. So the alternative names will be your metabolic syndrome, syndrome X, insulin resistance syndrome, deadly quarter, and revenge syndrome. Going to the next slide. So we already discussed that metabolic syndrome is a condition that includes a cluster of features. There are 5 main features which include abdominal obesity, high blood pressure, impaired fasting glucose, high triglyceride levels, and low HDL cholesterol levels. Now we come to the conclusion that out of the 5, any 3, if it is coming positive, then it is considered as metabolic syndrome. Any 3 out of the 5 fulfills the criteria of metabolic syndrome. So the patient presents with, suppose, our high blood pressure, impaired fasting glucose, high triglyceride levels. They must be suspected of metabolic syndrome. So now let's talk about the prevalence. Worldwide in adult population, it is around 20 to 25%. Whereas in ICMR data in India, we study, it was found that 72% population has low HDL and 30% have high triglycerols. So it's a non-communicable disease very prominent nowadays in the developing modern era because of the changes in our diet habits. As per the AHA, American Heart Association, metabolic syndrome doubles the risk of CVD, cardiovascular disorders, and 4 times to 5 times involves the risk of developing diabetes. So we can easily see that it's a very serious condition because of all the factor culminating, and when they occur together, like high LDL, low HDL, overweight, high blood pressure, when they occur together, they actually increase the risk of some prominent and very dangerous disorders like cardiovascular disorders and diabetes. Okay, so this next slide we'll be talking about the typical how the patient presents. So here we have a typical, pardon,
You have to attach the same PPT. It is not moving actually.
it is not moving.
So is it the same PPT which is being attached?
Sorry for the delay, little bit of glitch around here. So we were discussing about the features. The main features would be including abdominal obesity, high blood pressure, impaired fasting glucose, high triglyceride levels, and low HDL and cholesterol levels. So these are the 5 criteria. When they together come into the picture, they give rise to metabolic syndrome. Okay. So having any of the any 3 out of 5 fulfills the criteria for metabolic syndrome. Patient having like obesity, abdominal central obesity, high blood pressure, or high triglyceride levels should always be suspected of having metabolic syndrome. Or, for example, low HDL, high triglyceride levels, high LDL, and impaired fasting glucose. Any of the three can be suspected of having metabolic syndrome. Okay. So we are discussing about the prevalence. The worldwide prevalence is around 20 to 25%. And in India, it was study found by done by ICMR, India-based study. Uh, it is said found that 72% population has low HDL and 30% have high triglycerol. So that means that we are at the risk and quite a risk of having this metabolic syndrome. Although it's a non-communicable disease, but it's still risky because of our recent diet habits, our lifestyle habits. And as per the AHA, metabolic syndrome doubles the risk of CVD and 4 to 5 times increase the risk of diabetes. So we can very easily assume and confer that it's a very risky disorder. Now, this is a typical presentation of our metabolic syndrome patient, where we have a typical central obesity on the upper side of the body. So you can see the abdominal striae, this abnormal location of fatty tissues, and too much of waist circumference. Waist to hip ratio is very high. Okay, so let's discuss about the risk factors. So there are various risk factors. First is overweight, obesity. There is a main problem. Second is sedentary lifestyle. It's a predictor for CVD events associated with central obesity, triglycerides, HDL levels, low BP, high BP, and impaired glucose tolerance. Then aging. The prevalence increases with age. Then diabetes mellitus. Approx 75% of type 2 DM or impaired glucose tolerance have metabolic syndrome. Coronary heart disease. 50% of CHD patients have metabolic syndrome. So we can now easily see that the more than 50% of CVD patients and 75% of diabetes are having metabolic syndrome. So that with the advancement of this metabolic syndrome, the disease is getting more worse. About 1/3 of MS patients have premature coronary artery diseases, and lipodystrophy is one of the cause, both genetic or acquired, having due to severe insulin resistance. Genetic lipodystrophy is a different cause that can also lead to metabolic syndrome, whereas patient have taking insulin daily can also have lipodystrophy that can also cause insulin resistance. And ultimately, insulin resistance means our diabetes and more advancement of the metabolic syndrome disease. What are the key signs? Let's discuss about key signs and symptoms. So first of all, the key sign of metabolic syndrome is central obesity, also known as visceral male pattern apple-shaped obesity adiposity. It is characterized by adipose tissue accumulation predominantly around the waist and trunk. And the word visceral is very important because the distribution of fat is around the organs, which are not easily metabolized. Tissues, subcutaneous tissues having the fat under, it can be easily worked out with the help of exercise or diet control or rigorous going to workout or walking, brisk walking. But if the fat is visceral and accumulation is too much, then therefore we will be having definitely problem. Now, increased blood pressure, another sign. The lipoatrophy, another sign, and acanthosis nigricans, another sign. So, lipoatrophy already discussed that abnormal distribution of fats in the body, because we should have a uniform distribution. Now, if some parts of the body have no fat, some part of the body have too much of fat, so that is what correlates with visceral obesity. And acanthosis nigricans is a feature like darkening of the skin areas. So these features are signs that a person is having associated with that those three our criterias, those five features combination will provide us to diagnose with metabolic syndrome as well as the markers. So other associated conditions would be cardiovascular disorders, increased risk for new CVDs, ischemic strokes or PVD. Then another will be our type 2 diabetes mellitus, increased risk by 3 to 5 folds. Non-alcoholic fatty liver disease or non-alcoholic steatohepatitis, hyperuricemia will be there. PCOS prevalence around 40 to 50%. So especially we see PCOS in obese women. So their prevalence is very high, 40 to 50%. And obstructive sleep apnea, commonly seen with obesity, hypertension and insulin resistance. So these are the other associated conditions with metabolic syndrome, especially gout, hyperuricemia, PCOS, OSA. These are very serious problems. Okay, let's start talking about our this thing or controllers of appetite and pathogenesis. What is a pathophysiology? Now we have already discussed previously that diet is one of the most common factor. Diet and obesity, they are extremely related. So here on the slide we have, on the right part of the screen we have which parameters which will increase our appetite, and the left we have decrease appetites. So right side is orexigenics. Orexigenics are compounds or proteins which will stimulate our hunger and appetite, and orexigenics are on the left side where it will decrease the appetite. So any dysregulation between them due to genetically or other problems will have definitely lead to obesity. So we can use them as markers as well, special markers. For example, let's talk about a research study done in pediatric patients regarding alpha melanocyte stimulating hormone and AGRP, agouti-related peptide. So it was found that alpha melanocyte stimulating hormone is the one which suppresses appetite. Pediatric patients who were obese were having less amount of alpha MSH and high amount of AGRP. So this dysregulation is seen. Definitely, it's a quite alarming because they have done the analysis through ELISA, and we can see that significant difference was there between the control group and patient groups. So in obese patients, these factors which will decrease our appetite are less. So obesity is affecting in a very severe rate of progressing of the metabolic syndrome. Patients having increased amount of neuropeptide Y, MCH, agouti-related peptide or exons, they generally will be obese. For example, let's take the example of ghrelin. Ghrelin, what it will do, it will activate the AMP activated protein kinases. Those will go to the thalamus and induce the transcription factors. And these are the transcription factors, MCH, AGRP, orexin, and they will stimulate the appetite in the hypothalamus. So any dysregulation between our anorexigenics and oxygen due to genetic level or other problems will lead to obesity and finally metabolic syndrome. So these are our genetic causes. Okay. Now, once a patient is obese, what are the complications that we are facing in metabolic syndrome? See, adipocyte is a cell which is totally completely responsible for storing of fats. Now, when the nucleus will be shifted to the extreme corner of due to extreme amount of fat cells, their trouble started happening. Now these adipocytes will start releasing various factors. If we go from clockwise, like leptin, adiponectin resistant on the top, then comes inflammatory cytokines, TNF alpha, IL-6. Then comes free fatty acids, glycerol. Then enzymes, then aromatase, then angiotensinogen, RBP, retinal binding protein 4. Then the factor D or adipocin. These are all the factors which are released by our adipocytes. And we all know that metabolic syndrome is complicated because of these factors. Like there will be peripheral vascular disorders, there will be central vascular disorders. Like due to that, we will be having cardiovascular problems. Insulin resistance. Insulin resistance is linked with leptin and resistin. So these are the two compounds, leptin and resistin, where they actually modulate the insulin secretion from pancreatic beta cells. It has been found that in obese patients and in metabolic syndrome patients, leptin and resistin levels are very high and adiponectin levels are very low. So leptin has a capability of metabolizing glucose independent of insulin action, and also leptin modulates the secretion of insulin. So what is happening? Leptin cannot modulate in very high condition of obesity. Leptin loses the capability on acting on its receptor. So there is leptin resistance as well. So due to leptin resistance, it cannot stop the secretion of insulin. It cannot modulate the secretion of insulin from beta cells, and insulin levels keep on rising. So once the insulin levels keep on rising, there will be more accumulation of fats because insulin is responsible for storage of conversion of glucose into into fats. Actually, they help in the enzymes, which actually will do the fatty acid synthesis. So resistin also the same thing. Patients having obesity were found to have high levels of resistin. And adiponectin, on the other hand, which acts as anti-inflammatory. Suppose adipocytes are also releasing TNF alpha IL-6. So adiponectin cannot inhibit them. Adiponectin is an adipokine which is responsible for inhibiting the inflammatory markers. So inflammatory markers are getting very high up, and adiponectin cannot control them because adipocytes when the adipocytes are full of fats, the secretion of adiponectin decreases. As we know that as the adipocytes are full and our obesity is too much, that there will be definitely release of free fatty acids and glycerol. So those free fatty acids and glycerol will further potentiate the effect of insulin resistance. Then we have enzymes aromatase. These aromatases are specially found in the fat cells, and they will convert testosterone to estrogen. So what happens is hormonal dysregulation happens. Patients started developing gynecomastia or some other problems. If infertility also happens because of these aromatase enzymes. Then we go to the left to angiotensin and RBP4. So RBP4 is also an inflammatory marker. So here we are discussing about the markers. So TNF alpha, IL-6, RBP4. These can also be assessed to diagnose metabolic syndrome. Then angiotensin. Angiotensin is increasing. It is responsible directly for increasing the blood pressure. So the renin, aldosterone renin pathway. So this is how we see that how come the fat cells are responsible for too much of insulin resistance and hormonal dysregulation as well as cardiovascular problems. Why now we understand why there is an increase in double fold of CVD as well as 4 times to 5.5 times risk of having diabetes in metabolic syndrome. Now let's talk about this slide. How insulin resistance is happening and more worsening the effect. Now once insulin resistance is there, insulin cannot act on its receptors. So once the cells are not, insulin is responsible for storage of fat, conversion of glucose and other into fats, triglycerols storage parts. Now this when insulin is not cannot work, so lipolysis by LPL will begin. Lipoprotein lipase will started acting. Now this lipoprotein lipase will break down the fat cells and increase the abundance of free fatty acids. Now these free fatty acids ultimately it will injure our pancreatic islets and will cause hyperglycemia. The pancreatic islets, once they are injured, they will not be able to secrete more amount of insulin, And already we have high amount of insulin in the blood due to leptin resistance, and those insulin are circulating but all with no effect. So therefore we develop hyperglycemia and type 2 diabetes. Okay, let's go to the next slide. In this next slide, we will discuss about the other factors like genetic factors and lack of exercise. For example, insulin resistance, visceral obesity, hypothalamo-pituitary axis dysregulation, and atherogenic dyslipidemia. Now, as we have free fatty acids and low levels of ApoB100, ApoA, so they will actually leads to low HDL, high LDL, and this will cause metabolic syndrome. Then, due to dysregulation of HPA axis, there will be too much of hypercortisolism. As we discussed earlier, also that fat cells will secrete angiotensin. So this angiotensin, renal angiotensin, this also dysregulation causing high blood pressure. Then this fat cells will release or cytokines like TNF alpha, IL-6, CRPs. So these will also help in the um, activity of inflammation inside the vessels and all of the body, causing cardiovascular risk factors, stroke. And then ultimately, we already discussed about insulin resistance. So this high level of insulin is there without any effect, and they will cause hyperglycemia and diabetes. On the right side, we saw that how we can get coronary artery disease with the help from obesity. So with obesity develops insulin resistance, dyslipidemia, hemodynamics disturbances. So we can easily correlate the pictures on the left and the right. Procoagulation, pro-inflammation, elevation of inflammatory markers. So for metabolic syndrome, we can also use these inflammatory markers like TNF alpha, IL-6, CRP, resistin, leptin. So resistin, leptin are from adipokines. They are from the fat cells. They will be really very high in amount in the blood, as well as low adipokines. Adiponectin will be there. Okay, so let's go to the next slide. Okay, then and we discuss about the common markers like fasting blood glucose level, fasting triglycerol, HDL cholesterol. So we can use all these parameters for the diagnosis of metabolic syndrome. Fasting blood glucose will be high, fasting triglyceride will be high, HDL cholesterol will be low, microalbumin will be there. So if a patient is having vascular problems, so due to renal vascular problems, there will be microalbuminuria. That is one of the diagnosis we can diagnose metabolic syndrome. In insulin resistance, we can find out with the help of insulin fasting levels, then fasting levels of blood glucose, calculating HOMA-IR index, and also C-peptide. Then HSCRP, high sensitivity CRP, is a very good marker for cardiovascular disorders. So patient having cardiovascular disorder or metabolic syndrome, quantitative CRP as well as high sensitive CRP can be used. Patient having diabetes, hyperglycemia, we can use HbA1c. Then other significant markers would be lipoprotein A. Lipoprotein A is considered as a very good marker for cardiovascular disorders. Then apolipoprotein B100. So apolipoprotein B100 is present in VLDL and LDL. So these are a very good marker for our metabolic syndrome. What is we can do a common lipid profile test. After doing the lipid profile, we can see the special ApoB100 levels and directly correlate with LDL levels. Inflammatory markers already discussed: IL-6, TNF alpha, CRPs. Then RFT we already discussed microalbumin and hyperuricemia. So patient metabolic syndrome also develops gout, and especially those patients have prone to alcoholism in and obesity, they will definitely develop hyperuricemia because alcohol will alter the pH and uric acid will precipitate into the joints. So and thyroid function tests. So patient of metabolic syndrome will have abnormal metabolism and BMI. So due to that, thyroid function is also a marker. Then homocysteine is a very good marker for cardiovascular problems because homocysteine is known to be damaging as a the intimal layer of the arteries. Where once the intimal layer of the arteries are damaged, this LDL, small dense LDL, and they can easily and triglycerol which will convert to small dense LDL and LDL oxidized LDL. They will go and attach to the intima of the artery and cause plaque formation and cardiovascular accidents. So these are all the potential markers for our metabolic syndrome. Then for PCOS, we can definitely do all these tests like hormones are there: testosterone, luteinizing hormone, follicle stimulating hormone, anti-Mullerian hormone, inhibin B. So these are the markers very prominent for PCOS diagnosis. Patient who are having central obesity and metabolic syndrome develops PCOS due to insulin resistance. So in the PCOS patient also we can measure insulin resistance HOMA index as well with testosterone, LH, FSH, AMH, inhibin B. Because PCOS, what happens? We have a problem with rupture of follicles. Those rupture of follicles are directly dependent on the insulin level. So definitely, patient having metabolic syndrome will be having insulin resistance. Due to that, the follicles don't rupture, and also we have dysregulation of hormones. Now let's talk about the individual markers. For example, the common markers which we use daily. So according to EGIR and NCEP, like European Group for Study for Insulin Resistance and National Cholesterol Education Program, which is a US based education program, they confirm that fasting glucose should be less than 110. But IDF, International Diabetes Federation and American Heart Association, says that fasting should be less than 100. So if we take around 110 or 100, that can serve as a marker for reference range for our fasting glucose, especially for metabolic syndrome. Then we go for fasting triglycerols. 150 mg is quite common and given by IDF, NCEP, and AHA, whereas more than almost and also WHO also 1.7 millimole or 150 milligram per deciliters. These are the criteria for diagnosis of metabolic syndrome for according to the triglyceride levels. Triglyceride level should be less than 150. Then HDL cholesterol, it should be always more than 40. If it is less than 40, then definitely we should suspect metabolic syndrome for males and 50 for females. And this is quite a majority of have given like EGIR, NCEP, and AHA into the recent guidelines that HDL cholesterol once less than 40 mg in males and 50 in females, then it should be considered for metabolic syndrome. Okay. Then for insulin resistance, we do HOMA-IR index. It's a calculated index. We measure fasting insulin, then we measure fasting plasma glucose. Then we multiply fasting plasma glucose with insulin and divide by factor 22.3. Now this range, this 1 and 1.9, 2.9 is an international range. For India, it is less than 3 is absolutely no resistance. 3 to 5 is moderate and more than 5 is severe. And in this, in the international criteria, it is 1 is not normal, more than 1.9 it is early resistance, and 2.9 is significant resistance. So therefore, why it is important? Because insulin resistance is one of the primary cause for metabolic syndrome, where measuring the insulin resistance is very important. So in this HOMA-IR index, we can easily come to know that even if the patient is having normal levels of fasting or postprandial or random glucose, if the HOMA-IR index is coming into the danger zone, then we can predict that okay, this patient may have a future problem. That's why this test is very specific and significant. And another, we have urine microalbuminuria. We have already discussed previously that more than 2 microgram per minute or albumin creatinine ratio more than 30 mg per gram, according to WHO, is considered as dangerous or kidney problems. And HSCRP is also a valuable marker for NFALD as well, because we have already seen that NFALD is other associated disorders, NFALD and NASH. Okay, next slide. Physical markers. Physical markers are those which we cannot estimate quantity directly, but qualitatively we can use. Like for example, uh, waist circumference more than 40 inches in male and 35 inches in female, according to AHA and NCEP. Waist circumference more than 37 inches in males and 31.5 in females, according to EGIR. So regarding that, like if you keep around 38.5 or 40, better is then we can easily make the diagnosis on the physical parameters. BMI, if it's more than 30, according to IDF, it's considered as dangerous and part of metabolic syndrome, as well as high blood pressure. Okay, so and then so lastly, I would like to conclude that metabolic syndrome is a modern world disease affecting 1/5 of the world population, very prevalent, very high risky. Prevention is always better than cure, and awareness is very important. People actually don't know about the lifestyle modification processes and diet habits. People actually are not aware of that metabolic syndrome X. That is a very serious disorder and especially the diet pattern should be changed. So these culminating factors are playing a very big role for ongoing advanced metabolic syndrome, and that's all. So actually, I am not audible. So not audible.
Thank you,
Yeah.
Dr. Abdul Rahman, for a very informative presentation on this important subject. We'll go ahead and take some time for questions now. Just a reminder, please be sure to type your questions into the question box in your control panel. So it looks like some questions have come. So one of this is what can be the uh, diet modifications for subjects with metabolic syndrome? As you have mentioned about the diet modification, so what could be that? If you
Okay.
can,
So yes, diet modification would be like having Mediterranean type of diet, having high fiber diet. For example, uh, high fiber will actually reduce the absorption of carbohydrates and lipids. And Mediterranean diet includes mainly monounsaturated fatty acids. So what monounsaturated fatty acid does is it increases HDL levels and decreases LDL levels. So that's how we can prevent our cardiovascular accidents. And with Mediterranean diet, there has been researches have been shown, recorded that people generally do well. They decrease the blood pressure very quickly, they reduce the weight, and they also come back from their cardiovascular risk factors. So having monounsaturated fatty acids in the diet and exercise, as well as high fiber content, is a type of diet that's specially advised for this type of patients. Yes, sir.
right. One more question I got who has asked for please elaborate little bit about the HOMA IR index.
Okay. So HOMA-IR index is actually used for calculation of insulin resistance. That we already saw in our slides that how insulin resistance is playing a role in developing diabetes. That is one of the most non-communicable disease, dangerous disease nowadays, and it is increasing in a very rapid way. So what we do is we analyze fasting glucose, we analyze fasting insulin, and then we calculate the HOMA-IR index. According to the index, we can notify the patient that which status is the he or she is in. If it is within the range, then fine. If it is in more than the range, then we can predict and warn the patient and educate the patient that you are in the serious condition and it can prolong for diabetes. So this HOMA-IR is a very good index, and it's a calculative index used for prediction of insulin resistance, also for the diagnosis, and it's quite specific.
Yeah, also related to this HOMA-IR index, another question that please clarify about the BRA, biological reference interval of
Yes.
HOMA-IR with
Okay.
significance. Yeah.
So the biological reference that I was given in the slide, that is the international reference, that is 1, 1.9 and 2.9. If it is less than 1, it is okay. No, no problem at all. If it is more than 1.9, it is an early risk, means the patient is in early stage of getting resistance. And if it is more than 2.9, definitely the patient is in risk. There is an international level. But in India, we follow 3, less than 3 is normal, 3 to 5 moderate risk or early risk, and more than 5 it is definitely a significant risk. So less than 3, 3 to 5, and 5 more than 5 for Indian population, and 1, 1.9, 2.9 for international population. Because as we see that India is a diabetic capital. Last for the last 10 to 20 years or 2 decades, patients the number of diabetic cases have risen a lot, and researchers have given us these values only for our population specially.
It looks like we have covered the questions what has come now. Dr. Abdul Rahman, is there anything else you wanted to cover before we wrap up?
Before the wrap up, I would like to say only one thing, that regarding the diet modifications, these are very important, and awareness is very important because people are not aware of the syndrome. People are generally aware of individual disease like cardiovascular problems, diabetes, but culmination of all the things, high BP, cardiovascular problems, diabetes, low HDL, or dyslipidemia with hyperuricemia. So combination of all, people are not aware. So we have to spread awareness. Then second, we have to talk about the diet management and lifestyle modification. So if these three things are taken into consideration, I think that we will really come back, take a leap backwards from the disease progression and reduce the disease burden.
Great. So, thank you everyone. We appreciate you being here. And a recorded version of this webinar will also be available. Thanks again for joining us today, and we'll see you next time again. Thank you.
Thank you, both of you. Thank you.